Hello, my name is Götz von Wichert. I'm the head of the Department of Gastroenterology here at Ulm University, and I'm also one of the directors of the Comprehensive Cancer Center. And it's my pleasure to present data on early stages of colorectal cancer. And my talk is divided into three parts, where the first part addresses epidemiological questions and staging procedures. So, this is part one, in which I will discuss the epidemiology of colorectal cancer, and I would like to show some data on staging procedures in colorectal cancer. If one looks at the number of new cases per year, one can see that colorectal cancer makes up the third most common cancer in men and women, with roughly 70,000 newly diagnosed patients per male and females alike. If one looks at the data for the United States, we reach numbers of roughly 150,000 newly diagnosed patients per year, from which 100,000 are colon cancer and 40,000 rectal cancer. This number relates to 50,000 deaths caused by colorectal cancer, and almost 40% of all patients will ultimately develop metastases. If one looks at the trends in colorectal cancer mortality, it is obvious that in some countries we have rising incidences, especially countries that are adopting a Western living style, such as Croatia, Russia, or Romania, also Southern America. But in other countries, namely the Western countries, incidences are decreasing, either due to increased awareness of the disease and screening programs that are in place, or due to changes in the way people live. Colorectal cancer is a disease of the elderly. If one looks at the age distribution of colorectal cancer patients, and these are numbers from the Robert Koch Institute, which is the agency in Germany that basically keeps track of newly diagnosed cancer patients, one sees that especially above the age of 60, the incidence rises dramatically in male and female patients. Some risk factors have been identified that are predisposing for colorectal cancer. Besides race and ethnicity, especially the age, which I have already shown, is critical, and colorectal cancer is diagnosed in more than 90% above the age of 50. But there are also hereditary conditions which predispose for colorectal cancer. A previous history of colon cancer adenomas increases the risk to develop colorectal cancer again, but also a positive family history of colon cancer increases the risk of colorectal cancer in an individual patient. Especially syndromes of several cancers, such as HNPCC, with a family history of endometrial, cervical, ovarian, or breast cancer, includes an increased risk of colorectal cancer. If one looks at the risk in the general population, one has to assume that roughly 6% of all patients or people will develop colorectal cancer during the course of their life, which is transferred to 1 in 16 people. If you have a first-degree relative with colorectal cancer, the individual risk is doubled to tripled, and if you have 2 first-degree relatives, the risk increases even further, which is also true for patients where first-degree relatives were diagnosed with colorectal cancer at a young age. Especially if you have multiple first-degree relatives with colorectal cancer, the risk goes up to 50%. But there are also other diseases, such as long-standing chronic inflammatory bowel diseases, such as ulcerative colitis or Crohn's disease, which predispose for the development of colorectal cancer. And there are also other rare diseases, such as acromegaly, which predisposes for the development of colorectal cancer. If one looks at the distribution of causes of colorectal cancer, one sees that most of the cases are sporadic colorectal cancer, which roughly 80% of the newly diagnosed cancer cases. But you have a proportion of 10 to 15% with a positive family history, and the other predisposing diseases such as H and PCC, I will discuss that later on in further detail, or familial adenomatosis polyposis, FAP, is associated with an increased risk of colorectal cancer. But the majority, which is the point here, is a sporadic disease. If one looks at the anatomical distribution of colorectal cancer, one sees that colorectal cancer occurs in the left colon predominantly, especially in the rectum and in the sigmoid colon and in the colon descendens, which is almost 2/3 of the colorectal cancer cases diagnosed is in the left colon. But colorectal cancer is also present in the right colon, in the cecum with 13%, in the colon ascendens with 9%, and in the colon transversum with 11%. The problem with colorectal cancer is that the diagnosis is made late during the course of the disease. And you can see that the symptoms that occur in patients with colorectal cancer are fairly unspecific, reaching from pain, a palpable mass in the abdomen, to rectal bleeding or changes in bowel habit. Since the overlap to other diseases is so common, patients rarely find the way to the doctor to be diagnosed early with colorectal cancer. Now I would like to talk a little bit about staging procedures in colorectal cancer. In Germany, we have the so-called S3 guidelines, which basically relates to the security level of certain laboratories, where S3 is the highest security level, and therefore S3 guidelines are the guidelines with the highest level of evidence. These guidelines basically get their data from either systematic overviews of randomized controlled trials, meta-analysis, or other types of clinical data. And according to the evidence level, you can see with the decreasing evidence level here that you have here meta-analysis of randomized controlled trials going to the all or none principle here, or to systematic overviews of case control studies. And therefore we can graduate the level of evidence that is behind a given set of data. And in addition to that, a panel of experts discusses the available data and comes to a given consensus, where you have a strong consensus with you if you have agreement of more than 95% of the participants, and you have no consensus if you don't have agreement of less than 50% of the participants. So these data are then transferred from the evidence level to a recommendation level, and the data that are available are basically associated with evidence levels and recommendation levels. And the German S3 guideline, where the English version is also available in the additional reading, basically defines obligatory staging procedures in colon cancer and also rectal cancer. Obligatory is the digital rectal exam. Obligatory as well is a complete colonoscopy with biopsy. In case you have an impassable stenosis in the colon due to cancer, a complete colonoscopy is recommended postoperatively within 3 to 6 months. In addition to that, abdominal ultrasound is necessary in order to screen for metastases, and as well as a chest X-ray in 2 planes, and a CEA test in order to have a parameter to follow after curative surgery. In addition to these obligatory staging procedures, there is a recommendation for spiral computed tomography or MRI of the abdomen and spiral computed tomography of the thorax, which is supposed to be useful in individual cases. Actually, most of the centers in Germany and also in other countries in the Western world do standard spiral computed tomography of the abdomen and the thorax as a standard screening procedure in patients with newly diagnosed colorectal cancer. There are also obligatory staging procedures in rectal cancer. One is the rigid rectoscopy, in order to determine the precise height of the tumor localization, and an endoscopic ultrasound in order to determine how far the tumor is penetrating into the wall of the rectum. But also here there are some useful examinations recommended, and this is the pelvic CT or MRI as an alternative method to the endoscopic ultrasound, and gynecological examinations and cystoscopy if a T4 tumor is suspected. Anal sphincter manometry is certainly not a standard procedure. If these procedures are performed and data are available, staging is critical in order to risk stratify a given patient. And there the TNM staging system is established as for many other cancers, where T0 is no evidence of a primary tumor, going to a tumor that invades the submucosa to the muscularis propria, and the T3 tumor goes to the subserosa, and the T4 tumor invades other organs or structures. In addition to that, the number of lymph nodes that are occupied by the cancer is quantified, where 1 to 3 lymph nodes is N1 and more than 3 lone lymph nodes is N2, and then metastases are graded with M0, no metastases, and M1 metastases. This TNM staging, which is also called UICC staging system, which comes from the French Unité Internationale contre Cancer, is related to different stages reaching from 0 to 4, where basically you have early stages, which is stage 1 and stage 2, where you have a tumor without lymph node metastases, and you have locally advanced cancer, which is basically stage 3, which has NET but has a lymph node metastases, and stage 3B if you have advanced lymph node metastases, and certainly stage 4, where you basically have the state where the cancer has produced metastases. The older Duke staging, which is fairly common still in the US, is not as precise and therefore not commonly used anymore, at least not in most of the Western countries I'm aware of. If one transfers these data and combines that with survival, one sees that you have a fairly good 5-year survival at stage 1. You have a still good survival in stage 2, where you don't have lymph node metastases, but once you have developed lymph node metastases, 5-year survival starts dropping, and the more lymph node metastases you have, the more dramatic the drop is. In case you have distant metastases, the 5-year survival becomes really, really poor. The problem is that we still diagnose colorectal cancer at advanced stages. I pointed to that already, and you can see that here the colon cancer is diagnosed in almost 50% at these locally advanced or advanced stages, where lymph nodes are already incorporated into the disease, or you have distant metastases. The same is true for rectal cancer, but the cancer is far more distant, and therefore symptoms occur earlier, and therefore tumors are often diagnosed at earlier stages, with more than 50% in stage 1 and stage 2. So I think I have shown you that colorectal cancer is a disease of the elderly, that a positive family history of colorectal cancer is associated with an increased risk to develop cancer in an individual patient. Unfortunately, symptoms occur late and are unspecific, and advanced cancer has a significant impact on prognosis. Therefore, early diagnosis is crucial, and we have to take every possibility into account in order to diagnose colorectal cancer as early as possible. So thank you very much. This was the first part, and I would like to move on with the second part, which addresses prevention of colorectal cancer and screening procedures as well as endoscopical treatment.